Hello and welcome to the Evidence-Based Urgent Care Urgentology podcast. I'm Joe Tostano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points, and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can prescribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier. Today on this podcast, we're going to talk about the March issue of Evidence-Based Urgent Care, which was about long COVID. We want to thank the original authors, Dr. Chen, Charles Pollack, Robert Rodriguez, and the peer reviewers Monica Smith and Hashem Zikri.
And also a big thank you to our very own Tracy Davidoff, who adapted the article for the urgent care setting and urgent care clinicians. We should mention that EB Medicine will be at the 2024 Urgent Care Convention in Las Vegas from April 13th to the 17th. Come see us at the booth to learn more about evidence-based urgent care and our onboarding courses for urgent care clinicians, including our latest, the Abscess course, presented by Dr. Patrick O'Malley. Also, right-sizing reimbursement, how to code for what you're owed, presented by Brad Lehman. And if you don't make it to the convention, be sure to go to ebmedicine.net to check out all of our evidence-based content developed to support you in your practice and help you in your patient care. So let's get into it. Long COVID.
Absolutely.
Yeah. There's a lot of names that go along with this, the COVID long haulers, post-COVID conditions. There's even this acronym that they've given it, PASC, which stands for post-acute sequelae of COVID. Still being defined, but I think we have a good idea about it. It includes a constellation of all sorts of symptoms that people are experiencing beyond 4 weeks after being diagnosed with an acute infection. Technically, for most patients, unless they're immunosuppressed, there's no live COVID virus around at that time. So it's not due to the infection. It's some kind of an after effect. What kind of symptoms have you seen, Tracy, or have you suspected these patients to have?
The most common ones that you're going to see with long COVID or PASC or whichever one of those things we're going to call it, dyspnea and fatigue are by far the most common. Cough also. We get a lot of people that come in, with cough. I had COVID 6 weeks ago, 8 weeks ago, and I'm still coughing. But we can see pretty much anything, any constellation of symptoms in a variety of body systems. Chest pain, palpitations. Some people will have arthralgias, myalgias, GI disturbance, nausea, vomiting, and diarrhea. Rash is something that we see a lot. We'll talk about a little bit later. Neurocognitive disorders. A lot of people complain of feeling just a little bit slow in the thought process or not being able to think as clearly as they used to.
Brain fog.
And some psychiatric concerns.
Can you imagine having COVID toes for 4 weeks? Ouch. I think, we're starting to get some experience with this, which always kind of informs our practice. And we always look to the literature to help us decide beyond anecdote what the right way to think about things is and how to begin to evaluate and treat people. But the literature is really limited on this because it's so new. Think about how we're learning new things about COVID almost every day as we were evaluating and treating patients. And now we're dealing with the aftermath. And there's a lot of descriptive literature, but not a lot of high quality literature to know exactly what to do.
There's certainly not any evidence-based literature. When patients ask me questions, how come we haven't figured this out yet? Or how come we don't know the reason for this? I say, look, it took us 100 years to figure out influenza. We're only on year 4 or 5 with COVID. So I think we've made incredible leaps and bounds in those 5 years compared to previous disease states. But you're right. There's really no evidence-based research or information available on COVID itself, but there's not a whole lot, and certainly not PASC.
Yeah.
So
trials and things.
Everything out there. So do you think we should maybe I know we've all beaten COVID to death and we're all pretty much experts on it, but do you think maybe we should just review it a little bit for sake of completion?
Absolutely. Well, recording in mid-March. What is it? Yeah, mid-March. And as of this time, we're about 3 years into the pandemic, and there have been over 676 million confirmed cases of COVID worldwide.
Wow.
That's just confirmed. So Many people never got tested, or sick, and some people had some clinical disease. So who knows, billion cases of COVID since it started. Of those folks there, we know about 6.9 million deaths, almost 7 million deaths. We've heard the names, five variants of concern, started with Alpha, Beta, Gamma, Delta. I think we're still dealing with Omicron, a lot of some types and long numbers after those, but not genetically different from the Omicron that started, I think, over a year ago. And of course, we've seen different symptoms and we've learned about different transmissibilities and severities and courses of illness with each of these variants. Been kind of a study in virology within the last 3 years. We've all become really good virologists, or at least understand a lot more about it. And as we know, that when people are sick with COVID, the acute disease that they get can be pretty varied. Some people have asymptomatic infections, easier to spread the virus that way. Some people have a mild cold. Some people get full-blown pneumonia, ARDS, and respiratory failure and need to be on a ventilator. Of course, we saw a lot more of those more severe patients at the beginning of the pandemic when this was a novel. Remember when they called it novel coronavirus? Because it was a
Yeah.
completely new virus, and no
Yeah.
nobody's immune system had seen anything like it before. So it hit people really hard. I think we take for granted that cumulative immunity we get to a lot of stuff just being alive and on Earth for a period of time. And our immunity remembers a lot of these infections that nobody had any memory for COVID. In general, when people have severe disease, we got in the habit of characterizing them as mild, moderate, severe, or critical because it helped us decide on treatment and the disposition from urgent care for them. And of all these patients, Tracy, who is at risk for developing long COVID?
Really no surprise here. It's the same people that are at risk for developing severe disease. You want to think about the same people that you prescribe antivirals for, the same people that you tell, look, you're at risk for getting a little sicker than your average Joe, no pun intended. People are the unvaccinated, the obese, the elderly, those people with diabetes, coronary artery disease, high blood pressure, people with pre-existing lung disease, such as asthma or COPD, those that are immunosuppressed, smokers who I guess innately have pre-existing lung disease because they're smokers. Those that are pregnant, chronic liver disease, or kidney disease are all at risk, more so than your average person, of developing long COVID. Anybody who's been admitted to the hospital or had severe disease, especially those with ICU stays or people that were in the hospital for a prolonged period of time, those are all at risk for developing long COVID as well.
All the usual suspects. Is there any evidence, Trace, that people who were treated with antivirals for their acute infection or steroids, or maybe the vaccination status, how many vaccines and boosters you've had, make any difference in whether you're going to develop long COVID or what the disease progression is going to be once you start to get those sorts of symptoms?
So again, there's not a whole lot of literature out there. There were some anecdotal studies. There are two larger studies. There was a VA study done which showed that nirmatrelvir actually reduced the risk of long COVID. There was also a UK study that showed that steroids will actually reduce mortality, again, but only in critically ill patients. And it also prevents lung fibrosis after ARDS. But it may actually increase long COVID manifestations such as the thrombosis, the cognitive disorders, neuromuscular weaknesses, and myopathy. Steroids good if you're super sick in the hospital.
Mhm.
Steroids bad if you're not super sick and may increase your risk for developing the long COVID. I guess it's a bit of a trade-off for the steroids.
Steroids always a trade-off.
So, Joe, what do you think the suspected pathophysiology of long COVID is? Is there any research out there?
Yeah, I think we're understanding more about what happens physiologically or pathophysiologically when a person gets an acute infection. There's inflammation of all kinds of organ systems and blood vessels specifically. And it seems like the thought is that inflammation persists, or the inflammation causes damage that then results in those ongoing symptoms for patients. Certainly patients who have an overwhelming systemic inflammatory response during their infection, those are the sicker people acutely and higher chance of effects afterwards. Inflammation is this interesting thing. It's induced by the infection, but a lot of it has to do with the counterbalancing actions of our immune system. This idea of CARs, or counterbalancing anti-inflammatory cascade, where all sorts of hormones and counterbalancing reactions to fight the infection and then to balance our own inflammation, those things get out of control. And they may be resulting in those long lasting symptoms, or even causing some pathologic changes in organs that are demonstrable that lead people to feel the way that they do. There was a lot of talk about the cytokine storm when people actually got to that stage, those critical acute illness. Is there persistent release of some of those hormones at a lower level where people aren't truly sick, but they continue to feel badly? We know that that sort of cytokine storm was, as you had mentioned, correlated with lung damage, hypocoagulable states, thrombosis. Some theories even talk about the ACE2 pathway, the angiotensin converting enzyme 2 pathway, which they feel is the entry point of the virus into cells. Of course, patients who are in sepsis and septic shock have poor perfusion of their organs, and a lot of patients who have septic shock on any basis end up not doing well in the future if they survive the sepsis. They can be restored and be alive, but they're not really quite the same as they were before they went through all of that.
Hey, Joe, wasn't there just something in the news about a lady who had a thrombotic episode and died from long COVID?
Yes, yeah, I think it was in People magazine. We were talking about that. She had gone and seen the doctors once or twice, and they dismissed her symptoms. She had some dyspnea, and they had dismissed her symptoms as, oh, this is probably long COVID. And she didn't get a workup, and she ended up having PE, dying from a PE. So I think that underscores the idea that though long COVID can have a variety of symptoms, you really want to be sure there's nothing causing them. Otherwise, doing something life threatening.
Yeah, I think she had been to the hospital several times and they missed the forest for the trees. It's a shame. So, what about specific symptoms of long COVID in an evidence based sort of way? Do we know anything about those?
Yeah. If you get the issue and you look at figure 3, there is a really cool graph that summarizes data from a number of studies. It talks about the range of, gosh, almost 2 dozen symptoms that people could present with after COVID. And it talks about the range of symptoms and then the average number of patients who experience those different symptoms. And certainly patients can have more than one symptom. Actually, really instructive. They're stacked from top to bottom. Obviously, you had mentioned fatigue, the worst. There's some pathophysiological changes like persistent ground glass opacification in the lungs, dyspnea, insomnia, difficulty walking, anxiety, depression. You talked about the psych stuff, cognitive impairment or brain fog. Cough is about a third of the way down the list, with about 20% of patients experiencing that symptom. There's even musculoskeletal complaints like aches, derm stuff, rash. I think that's probably more due to the inflammatory or autoimmune process that's still going on in patients. The interesting thing about the pulmonary stuff is obviously it's a pulmonary disease primarily, or a respiratory tract disease primarily. And I think of these long COVID patients maybe in two categories. Some people recover from the disease with true structural injury to an organ. And the lungs are one of the ones that's talked about a lot, like scar tissue from a really bad pulmonary infection with the disease. You expect somebody like that to have some sort of ongoing problem. If, a certain amount of your lung tissue is scarred because of the inflammation and inflammatory response that occurred during the infection, with the fibrotic remodeling that occurs and the damage to the blood vessels, microemboli in there, and then even once you start to lose your overall vascular volume, resulting pulmonary hypertension, when you can demonstrate those things in a patient, they're not going to feel well and they're not going to function as well. But there's even people who have symptoms, dyspnea, exercise intolerance, who, when you look at their organ systems, they don't have a reduced ES, or they don't have any abnormalities on a CT of their chest, let's say, and they still don't feel well and they still need some sort of rehabilitation. So people can have these symptoms when there's organ injury, but even when they're not, and that's maybe less well understood, probably some ongoing inflammation. In thinking about the patients with their heart stuff, we know COVID can cause myocarditis. Some people recover from that really well. They return to the state they were before, but some people it causes a cardiomyopathy. The heart muscle is permanently changed as a result. There's remodeling, and then their heart's just not the same. Their ES reduced, pump function's reduced. So those patients will have symptoms associated with that: exercise intolerance, leg edema, those sorts of things.
Yes, that's very important when you're talking about sending an athlete back to play,
Right.
especially college level, professional level. That's a big deal. The one thing I didn't mention earlier on, this sounds familiar. Think about mononucleosis
Mhm.
and Lyme disease, the chronic Lyme. Most people get better, but some people have symptoms going on for months and months. So, even though long COVID is new to us because COVID is new to us, the thought of having a post viral syndrome following sickness
Mhm.
is not really new. I mean, that's been in medicine for a long time and it's puzzled a lot of people and
Yeah.
garnered a lot of research. The COVID portion is still in the infancy.
Yep. Epstein-Barr virus, chronic fatigue syndrome. Remember chronic fatigue syndrome?
Yep.
Yeah.
Yep. Chronic Lyme.
Yeah. So Tracy, a patient walks into your urgent care. They recently had COVID and they had their acute infection seems to be gone. No more fever, no more feeling sick, but they still have some symptoms like we've talked about. They still can't exercise well, or they're dyspneic, or their body hurts. How do you know? How should we determine whether, oh, this is just long COVID, or could it be something more serious? What kinds of tests or evaluation are you thinking about, or do we know we should do in those?
So in the urgent care, we're probably not going to make the groundbreaking diagnosis of long COVID. Usually this is a diagnosis of exclusion. So our goal is to really rule out any underlying serious pathology, make that diagnosis, treat, stabilize as possible, and refer to the appropriate place. If it's someone who's having cardiac complaints, first of all, in most cases, you're going to refer back to the primary care doctor. But if it's someone that's having cardiac complaints or pulmonary complaints that you can point out with some diagnostic testing or whatever, you're going to refer them to the cardiologist, the pulmonologist, whatever. But we want to determine, as in every patient that presents to urgent care, determine who needs immediate evaluation and treatment and who can wait and follow up with their PCP for further evaluation. So nothing new compared to other diseases. Again, really super important. Remember, long COVID is a diagnosis of exclusion. You don't want to, like this poor lady that died of the DVT that was in People magazine, the PE, sorry. You don't want to immediately jump to, oh, this is long COVID because she had COVID 6 weeks ago. You really want to make sure there's nothing else going on. You don't want to do what is that story with the little kid, the crying wolf?
Yeah.
You don't want to
Mhm.
say, oh, she's here 3 times for shortness of breath. It's probably nothing. It's probably just anxiety. You really need to ask those questions. And if you've had someone that's shown up with cough 4 times in a row over the last 3 months, maybe make
Mhm.
sure you ask them, hey, did you have COVID not too long ago?
Yeah.
Also, remember, a lot of these patients will have premorbid conditions that got worse while they had COVID. It's established in research that diabetes gets worse after you've had COVID,
Mhm.
less in control, hemoglobin A1C goes up, asthma or COPD may get worse if there was any lung disease, CHF can get worse from a COVID infection. So make sure that the management of the chronic diseases are up to where they need to be. I mean, not something you're going to do regularly, but something that, you're going to make sure the patient follows up and make sure there's no instability that needs to be taken care of in the urgent care. Again, super important here. Do not just label people as long COVID without doing your due diligence. You have to rule out that an emergency or urgent condition doesn't exist. Make sure they don't have that DVTPE. If they're complaining of palpitations, make sure they're not having any arrhythmias going on that are from myocarditis. Any tests should be offered to rule out acute or life threatening conditions, which may, in the long run, support the diagnosis of long COVID. Another important piece, all patients from minimally symptomatic to critically ill, they can all develop long COVID. So don't dismiss it just because their symptoms were mild. I tested positive. I had a little cough. I was fine in a few days. Those people, although it's less likely for them, they also can develop long COVID. So you really have to keep that in mind and keep in mind that anyone who's previously had COVID can develop long COVID. I don't know about you. I'm still seeing people that are getting it for the first time. Everybody I know pretty much has had it three,
Yeah.
4, 5 times. But there are some people out there that are still getting it for the first time and they're getting sicker than the people that haven't had it before.
Right.
So they're probably also more likely to develop some long COVID conditions. So you really got to be a little detective and ask around and ask questions about it.
Yeah, and so, like you said, so obviously, if somebody comes in and they're sick, they're hypoxic, which you can actually see on the pulse ox, or they're having some symptoms that are worrisome for a cardiac problem, and you're really worried, we're going to stabilize them and send them right out to the ER or to a specialist, depending on their stability. But what can we do in the urgent care? Who can we treat? What facets of long COVID are we actually able to do something about in urgent care?
So again, after you've ruled out that there's no acute, urgent, life-threatening condition going on that you need to take care of, most symptoms are supportive. Cough, there's no studies with any viral respiratory illness really to show that a post-viral cough syndrome can be improved with any treatment.
Mhm.
So there's not a whole lot of studies out there. Some people will try some inhalers, some people will try some prednisone, but again, there's no proven benefit that any of this stuff works. A lot of times if you just explain to the person, look, you should slowly get better over time. Nothing serious going on here. You don't have pneumonia. Your lung function is looking okay at this time. Reassurance goes a long way. So a lot of times you can do that for the cough. There is some research for the cough about gabapentin using pregabalin or any antimuscarinic drugs. Stay tuned on that. Right now, there's no proven benefit. There's not a lot out there. There might be something coming down the pike in that in the future. Any medications that you start should be in consultation with a PCP. Remember, this is probably going to be a long-term medication, not something we want to keep renewing out of urgent care. Refer that person back to the PCP or to the specialist. Fatigue, again, you want to rule out other causes. Nothing says the patient can't have anemia from some other cause. And they're thinking that they're just still tired from having COVID and there might be something else going on there, some hypothyroidism, some anemia, that sort of thing. Do your due diligence and work them up as you would any other patient with that same complaint. There's really no treatment, diagnosis, or anything for neurologic or psychiatric concerns related to COVID. Again, there's no reason to do a stat MRI or a stat CT scan unless you see some neurologic symptoms that would warrant it. That's going to go back to your PCP or neurologist. There is some study using clomipramine for the psychiatric concerns related to long COVID. There's nothing proven on that yet. It's still under investigation. So again, stay tuned on that.
Yeah, a lot of the clinics that you're seeing that are clinics are beginning to open, and a lot of them at university settings for the management of long COVID. It seems to be a multidisciplinary team where there's a counselor and a cardiologist and a pulmonologist and a physiatrist, where the range of symptoms, it requires a lot of different, even experimentation. I know there's research going on in that also.
The VA is doing a lot on that, so
Yeah.
they're probably gonna have some research coming out of that soon.
These cough patients are interesting. I see a fair number of them. I'd say that one of the most common things you can wrap your hands around. A lot of people don't feel well for a long period of time, and it's a little bit more vague, but cough's this discrete thing that we have a mental kind of diagnostic process to go through. It's one of the most common things we see in urgent care. And in and among all those people who are coughing occasionally, you'll find somebody who's wheezing, who's never wheezed before, a 40 or a 50-year-old even, who has no family history of asthma, no asthma themselves, never needed an inhaler. And a couple of those patients had been treated with inhalers and came back for another inhaler. And they're in their sixth or seventh week after COVID. And they didn't really need it during the acute phase, but definitely an after effect. That's definitely someone where you can help if you're seeing them for that first time with the wheezing, start them on an inhaler, but do get them back rather than them coming back and getting a refill on an inhaler. They should have seen someone during that time to begin, maybe new onset asthma, possibly, or new onset some kind of bronchospastic disease as an after effect of COVID. So that's cool. There is one thing we haven't talked about that's not even included in this article.
Yeah, the altered taste and smell thing. On with alpha and delta, that was really a big thing. You could almost make the diagnosis with a patient came in complaining of that. And now not so much with Omicron, although I have seen it a few times. Sometimes it's just from congestion. That's why they can't smell, but do see it occasionally. But it's funny because patients will mention this pretty much every day that they have altered smell and taste from COVID, even when it wasn't their chief complaint. Hey, by the way, still not smelling 100%. What do you think that's from? Not really a serious thing. They're not gonna die from not being able to smell or taste, but actually, maybe you could. I mean, what if you don't smell that gas leak in your house or
Yeah.
you don't taste that bad milk that's gonna give you gastroenteritis? But yeah, like I said, it was even diagnostic for alpha and delta. It is due to damage to the olfactory centers in the brain. They did a lot of studies on this early on, necropsy studies on patients who had died from COVID, and they took their olfactory nerves and looked at them under the microscope, and they were actually calling it brain damage
Huh.
because technically your olfactory nerve centers are part of your brain.
Hmm.
And there's actually direct damage from the virus to the olfactory centers. I myself have really struggled with this a lot. It took me a year for my smell to come back after I had alpha.
Wow.
And yeah, that was crazy. And my taste is very different now than previously. Can you pass the hot sauce? Because I can't really taste my food. Never put hot sauce on my food. I do now. My taste in wine has completely changed. Like I said, looking at that, it's not really an urgent thing, but if you look at quality of life,
Mhm.
it's sure annoying to notice that. There is some treatment for it. They've looked at smell and taste training where you get three things that you're supposed to know what they smell like, and you taste them or smell them several times a day, and it's supposed to retrain your brain. I'm not sure it really works. I don't think there's really evidence that it works, but it's out there.
Might be a threshold. Yeah.
So, in conclusion, let's talk about our pearls and pitfalls because really that's what boils down all of these issues of evidence based urgent care. Just what you really need to know. Get to the meat of the matter.
Mhm. Sounds good. Yeah. So to summarize here, long COVID may be either the lasting effects of infection, it includes persistence of symptoms, or people may develop symptoms in their long COVID phase that they didn't have earlier. So we need to keep that in mind. Any patient whose acute illness was anywhere from mild to critical can experience it. If they had more severe disease to begin with, it's more likely, but even somebody with mild acute COVID can develop long COVID symptoms. As you had mentioned, it's worse in patients who have any and more premorbid conditions, so diabetes, high blood pressure, liver, kidney disease, cardiac issues. Those patients are more likely to get long COVID and their symptoms are probably going to be worse. Patients who had severe or critical disease initially, or patients who qualified for antiviral treatment during their acute phase, those patients are more likely. Actually, we didn't talk too much. I think you did actually say that, or one of us said that when we think about the risk factors where we're going to treat somebody for acute COVID, that's the same group of people who are most likely to get post COVID. It does kind of contaminate the evidence about whether treating with antivirals increases or decreases the risk because most of those patients are treated to begin with. It's hard to say. And denying them treatment to see if they're more or less likely to go on to long COVID would be a difficult study to do. Most common long COVID symptoms, dyspnea, fatigue, but there are 20 or more symptoms that are attributed to long COVID syndrome. So we can grab the issue, look at figure 3 and see all the symptoms which are attributable to the condition. We mentioned also it's a diagnosis of exclusion. If somebody's presenting to you with chest discomfort or shortness of breath, even without hypoxia or vital sign changes, a few weeks after their COVID infection, you need to run through your usual differential for those patients. Think about what their risk is, get EKG, because you're going to diagnose long COVID after you've excluded complications of COVID or conditions that anybody could get that we need to be careful with. A lot of patients come into the clinic with a self-diagnosis of long COVID. And there's a double-edged sword. They may be right. They may have researched it. They may have already had some sort of an evaluation, but you can't stop there. If there's been no diagnostic process to exclude those other things that could be potentially life-threatening, you have to do that. You got to do your due diligence. In terms of reflexively putting people on steroids for this, it's not something we probably should be doing until we get more research on it. And then, of course, these folks who are more likely to get it, who have premorbid conditions, one of the things that we should be doing, as well as making sure that their current symptoms, dyspnea, fatigue, is not a decompensation of their premorbid illness, that everything's still under good control with the conditions that we know they have already.
And we'll talk about some counts too. Remember, long COVID starts 4 weeks after the onset of COVID. Occasionally you'll get somebody in that's 3.5 weeks out. They're kind of heading for that long COVID. Comorbidities may contribute and should be addressed. So those people that have pre-existing asthma, COPD, etc., make sure that they're in well control
Mm.
of their illness. The goal in urgent care, again, can't say this enough, exclude other more urgent causes of symptoms and treat accordingly. Make sure that you fully diagnose and come up with a long-term plan. If it's something that's not urgent or emergent, you're going to leave that for the PCP. Reassure them, treat what you can, and leave the workup and the chronic management for the PCP. Don't ascribe things to long COVID until you've ruled out other things. Again, diagnosis of exclusion. Pound that into your brain. This is a diagnosis of exclusion.
Mm-hmm.
Testing is necessary to rule out acute or life-threatening differentials, cough. If it's been cough for a month, 2 months, that person probably needs a chest x-ray to exclude out some other disease. Make sure they don't have that hiding lung cancer or that pleural effusion from the colon cancer that nobody's ever diagnosed. Don't just hang it on the long COVID.
Right.
Absolutely be sure the patient has good follow-up. It's actually good medicine to be sure in an urgent care that everybody leaves with some sort of follow-up, but no one's more important than these people. They really need to make sure if they don't have a PCP, you give them some phone numbers to call, or you give them some way to make a connection to get a PCP to follow them up. And above all else, be compassionate and understanding. This is really frustrating for patients. They have a new disease with not much research, so we don't really know what's going to happen to them in the long-term future. The literature is, so little of it out there, and that makes it very frightening for both us and for them.
Mm-hmm.
Support care is medically as well as psychologically supportive care can go a long way. Look, you're not going to die from this, but you're probably not going to be happy for a while. This is not fatal. A lot of times that's all they want to hear is that they're going to be okay in the long term. Sometimes they just want an ear to talk to and they want to know this is going to get better eventually. So with that, I think we've pretty much reviewed that whole article there.
Yeah, thanks for the review. That was really good. I'm looking forward to next month.
I am too. I wonder what it is.
Thanks again to our original authors, as well as our own Tracy Davidoff, who adapted the initial issue for urgent care. We hope you enjoyed the discussion, learned something, and we'll be ready for more soon. And again, come visit us at the booth at the 2024 Urgent Care Convention in Las Vegas. That's from April 13th to 17th. We look forward to seeing you.
Thanks, everybody. I want to thank everybody for listening to this month's evidence-based Urgentology podcast about long COVID. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.